hematuria that can be coming from the kidneys itself. That could be secondary to glomerular damage. We can think of like glomerulonephritis, things like that. You can actually have it coming from somewhere within the urethral system. You can think of if you have kidney stones, trauma can also damage both the kidneys and the ureters. It can be coming from the urinary bladder. The most common thing that we think of, I think, especially in the ED, is this some sort of hemorrhagic cystitis. But it can also be a tumor in the bladder. We do see it a lot with our patients that have hypertrophic prostate, and that can cause hematuria simply because the bladder is contracted and gets basically a closed door and it can damage the bladder. And of course, we can have it from the urethra as well. That tends to be secondary to trauma, although it could be secondary to certain types of infections. Okay? We also see a lot of proteinuria. So for me, this is one of the things that was most interesting, because I feel like with a lot of the UAs that we send and we get back, there is trace proteinuria on it. And whenever I talk to attendants and I'm like, oh, by the way, this patient who's seemingly healthy and has no history of hypertension has proteinuria, the answer is usually like, yeah, it's fine, send them home. And so with this, it brought it back to clinical significance for me. So proteinuria is clinically significant, meaning that we care about it when it's about 150 micrograms per day, which is about 10 to 20 milligrams per deciliter. A trace result on the dipstick is actually 5 to 10 milligrams per deciliter, which is below the area that which we pick. It's below the clinical significance. So that's why usually when we see trace proteinuria on a UA, our attendings, or even us if we're smarter than me, are usually like, it's fine, we don't need to worry about it, we don't need to go chasing this down. So usually the proteinuria is defined with just this 1+, 2+, 3+. There are actual ranges attached to each, which is why I put them up here. The more proteinuria you have, naturally, the more worried you become. There are different sources of proteinuria that reflect basically different patient populations. Proteinuria in a child is usually concerning for things like glomerulonephropathies. You can have it, as this slide basically organizes it, as a pre-renal, meaning that you have just a lot of protein in the blood that the kidneys are trying their best to filter out, but they're not able to filter it out. Just a note with this while I was doing my research, the dipstick is actually more specific for finding albumin in the urine. So while this slide does say that you can detect like Bence-Jones proteins, that's not always the case. You can have patients that don't have a proteinuria on it if you are suspicious for those types of proteins. You can also have a renal proteinuria, which is damage to the kidneys. Usually you see that with or hypertensive patients or patients with renal disease, that they've been having all of this excess damage to the kidneys for many, many years. So the basement membranes are just not as good. They're not as good as filtering out and reabsorbing as they should be. You can also have proteinuria with fevers, which we do see quite a bit in the pediatric population as well. Infection can cause it. We see that a lot less. Kidney stones can cause it, and you will see it with some sorts of glucose in the urine. So just an interesting tidbit with this picture. I'm not sure if it's actually true, but we were told when we were young in Jamaica that in the old days how they would test for diabetes is that they would have you pee next to an anthill, and the ant would actually go to your pee. Just a little bit of cultural knowledge in the middle of my lecture. So with glucose, the kidneys are supposed to filter the glucose it's supposed to be filtered by the glomerulus, and then it gets reabsorbed in the proximal tubule. Typically when you are seeing glycosuria or glucosuria, whatever you choose to call it, within the urine, it's a problem with the kidneys reabsorbing it. Usually we see it in our diabetics, and it's simply that the amount of glucose within the blood is overwhelming the kidneys' ability to reabsorb the glucose. So this is what it means when the load exceeds the reabsorption. You have so much sugar in the blood that though the kidneys are still functioning and reabsorbing it, you're not able to get all of it out of your urine. You can see this. You can see this not just with diabetics. It can be seen in pregnant women as well, and it's, I don't want to say less concerning, but it's a little bit more normal to see it with pregnant women, but it can be a concerning marker for diabetes in pregnancy, basically. I feel like we're pretty comfortable with glucose in the urine. We can also see ketonuria. Ketones are a product of metabolism. They aren't really supposed to be in the urine typically. We do see it with the things that we think of when we hear ketones, DKA. You can see it with alcoholics and starvation because it's a product of your body does not have enough glucose or doesn't think it has enough glucose and starts going down alternate metabolic pathways and you produce ketones. Another thing that was actually frequently mentioned in the literature that I was looking at is with ketonuria. While we think of it as pathologic many times, in this day and age, the ketone diet, ketogenic diet is a thing. A lot of times you just have to ask your patients, are they trying to adhere to this diet? Is this a reason why their ketones are very, very elevated? So bringing it back to the bilirubin and urobilinogen in the urine that I just never know what to do with a positive. So just basically reminding everybody, there are two forms of bilirubin. The form that you see within the urine tends to be the conjugated or the direct bilirubin because it is water soluble. This really shouldn't be in the urine. It's never normal. Urobilinogen, on the other hand, is a product of bile salt metabolism, and that is always water soluble. You can see this in the urine sometimes, and it is. Trace amounts are pretty normal. It's also excreted in the feces, so it's in the blood supply, it can get into the urine. So I basically tried to figure out if anybody's really concerned about this when they see it in the urine, because I do see bilirubin trace amounts in a lot of the UAs that we send off, and the data is basically saying this isn't ever normal, but we don't usually trace it down. With a lot of the papers that I was looking at, there are very few that talk about this simply because if you're very concerned for anything that would be causing like hyperbilirubinemia, you're also getting blood work, so you're very rarely being left with just the UA. However, there is one paper from, I think, 1997, so it's not really recent, that talks about if you have very large amounts of bilirubin in the urine in a patient that you do not expect, you have no reason to expect that they would have a hyperbilirubinemia. It is good if you haven't already gotten lab work to get lab work on them because there is a high correlation. It's specific but not particularly sensitive that there are elevations in LFTs. The paper went on to say a lot of these times these elevations in LFTs weren't clinically significant. They were transient or they never found a reason why the LFTs were elevated at that particular moment. So it's kind of do with it what you wish. With the hyperbilirubinemia, however, if it's very high, you can be concerned for bile duct obstructions. The urobilinogen in that case would be normal. You're not really thinking of urobilinogen being elevated in this. It can be a marker of liver damage. It's kind of where the LFTs come in because it's not a very good marker for it. With hemolytic disease, however, you expect to have the urobilinogen be very elevated, so you can think of that, especially with our sickle cell patients. We do send UAs on them. This can be a marker of basically how much blood cells are lysing in their blood and how much free hemoglobin they could be having. And then we get to the more interesting and controversial parts of the UA. So Luke esterase is an enzyme found in white cells. Whether or not the white blood cells lyse, you can have positive Lukes. Nitrites, on the other hand, occur when urine nitrates are reduced to nitrites. This is done by bacteria, typically gram-negative bacteria. However, there are apparently some gram-positives that can do this. So the real question with those two things is it comes down to what's the real clinical significance? Is you have positive Lukes versus negative Lukes, positive nitrites versus negative nitrites. So this has actually been looked at quite a bit. Luke esterase is a very sensitive marker for there being something possibly going on. The issue that we get into is not a lot of our UAs are perfect midstream captures. So it is very sensitive, but not particularly specific, 78% for a UTI. Nitrites, on the other hand, aren't very sensitive, but they are very specific. So typically, if you see nitrites, that's a marker that there is bacteria present in the urine, and it is acting on the If you have both together, I don't know if it mentions it here, but other sources quotes it like a 99% rate of there is a UTI here. Luke esterase by itself versus nitrites by itself, or if you have microscopy that also shows hematuria, these are all things that can push you towards there's probably a UTI here. So, like I said, we're bringing it back to the UTI. The question becomes then, we have all this information from the UA, especially with regards to the UTI. What should we be treating? What should we be saying if you don't have any symptoms, you should go home? It kind of comes down to, what do you think of as symptoms? So there is a paper that Dr. Sinner was actually a part of that came out about 5 years ago that talked about the different aspects of the HPI in relation to the UA, in relation to culture positive urine sample. The results were basically up in the air, you can almost say. So a lot of the things that we think of as highly correlated to having a UTI, things like dysuria, it's true, dysuria is very, very strong likelihood ratio that you do have a UTI if you're coming in presenting with dysuria. However, the other things that we kind of start to get worried about when you have this lower abdominal pain, when you have this back pain, are much less, have a much lower sensitivity and specificity. So this basically goes through some of the symptoms that patients presented with and whether or not, what the sensitivity and specificity of these symptoms were. So if you look at it, fever is very specific. In general, fever is going to indicate that you have an infection. If you have urinary symptoms on top of that, that makes sense. However, back pain, about 77% to 76% depending on the paper. Urinary urgency, still only in the 80s. Dysuria, depends on how you qualify dysuria. People who have just discomfort was much lower. There was another paper that talked about people who had true burning and painful urination where it was up to about 90% for the specificity. This one does also mention back pain. Back pain is in the 70s for specificities. The sensitivities for all of these aren't particularly great as well. So from all of the papers that I read through, and there were a good number of international journals that talked about this as well, because in some places, UA dipstick is not that common. You have to pay a lot of money to get it, so they don't use it as often. There isn't actually a lot of data that shows that the UA alone, if you just look at the UA for treating in terms of like urine culture positive versus HPI alone and treating changes the amount of UTIs that you're actually catching versus the number of people that you're treating who probably just have something else going on. However, when you use them in conjunction, the number of culture positive patients being treated for UTI does increase. It doesn't increase dramatically, but it does go up. And basically what it comes down to is that you have to have just the clinical history. So a lot of the times we look at the UA and we listen to our patients and we say, well, you know, the patient doesn't describe clear UTI, but they have flukes, maybe we should treat them. But as the papers that actually went through, Luke esterase isn't particularly specific for infection. If they have nitrites and they have any symptoms, even some of the symptoms that aren't as great, like back pain, that makes a lot more sense. You should treat them because nitrites do tend to be much more highly correlated with UTI. However, it kind of comes back to listening to your patient, talking to your patient. From a public health standpoint, there is an issue with treating everybody as if they have a UTI because it comes back to resistance. Rather than on an individual standpoint, most patients, what you are treating them for the UTI, a lot of patients don't have a reaction to it. So on a patient standpoint, it's not necessarily bad to over-treat and can actually be encouraged depending on where you are. From a public health standpoint, though, breeding resistance, not as great. So my take-home points for this are the UA does give us more information than UTI or than UTI. So there are certain things on it that you should listen to, even the specific gravity that I feel like I never look at. If you look at a patient-specific gravity and they're coming in complaining of urinary frequency and their specific gravity is very, very low, that could be an indication that they're having an issue concentrating urine, and that's why they're having a urinary frequency. If you see a patient come in that is here for something completely different, you send off a UA and they have very high bilirubin on it, we shouldn't just ignore it, especially if we haven't got lab results, because it can be correlated with elevated LFTs. As I said, that might not end up being clinically significant, but that's at least something that they should follow up with their primary care docs. Don't forget that the UA is not just telling you about the bladder and below. It can give you a lot of information on what the kidneys and the ureters are doing. It can also give you information on what's going on in the blood. Nitrites on the UA have greater than a 90% specificity for UTI. So if you see nitrites, especially in our pregnant patients, you should be treating it, even if they're not necessarily complaining of a lot of symptoms. Nitrites include esterases, the number of quoting greater than 96% specificity for UTIs, and there really aren't any great physical findings that are associated with a UTI. So sometimes, as it comes back to clinical gestalt, look at the patient, look at your UA. There isn't a great, this is a UTI, this isn't a UTI. These are some of my sources.
A few comments. I think the most important one is all the things you said are for sterile patches with like a Foley and not just clean patches with like hoping they wipe themselves off. Because you get a lot of contamination from the brain. With ketones, the kidney will filter ketones at the glomerulus, then it will also secrete them. So even a tiny drop of ketones in your blood will be positive in the urine. If you're going to look for DKA, it's really important to remember that you have to do the serum ketones for DKA. Because even a little tiny drop will be positive in the urine. It's not good enough solution.
That was great. I like your style. You're very relaxed. You probably had a look at your slides. You put a lot of work into it. You went through the journals. You had some really fun slides. I think you really a very, very good job of how to present something like this. A couple of comments. One is that in the old days, we wouldn't often send a culture, except if you were pregnant or septic. But I've actually gotten to send more cultures than I used to do, even on young women, because we're seeing so much resistance. So if I think someone has a UTI and I'm going to start treatment, I usually will send the culture, even though it costs more money, just because I'm afraid that when they'll come back resistant and they'll be more sicker. So I tend to do that more than the literature in the past has said. And I agree with what Mark said about the ketones. So just one other key about that is if you're having someone who's very sick with ketoacidosis, especially alcohol ketoacidosis, which we don't see as much here as I saw at Lincoln, but if you have that, then you don't want to just measure, if you can get it, just measure plain ketones in the serum, but you want to measure beta-hydroxybutyrate in the serum. When they're very sick, they mainly may be beta-hydroxybutyrate.
You talked a lot about specificity, but the sensitivity of the UA is not that great. If you have a patient and you're not positive, I have pre-test positive likelihood of having a UTI. A UA shouldn't really skew you off of that. You can have a negative UA, but if you have a young female complaining of frequency, dysuria, and it was like my last UTI that was culture positive, then you should treat that. Or don't even send the UA. I think that's something that I do a lot on fast track. If you have somebody who's classic UTI symptoms, you don't need a UA to tell you that they have UTI.
So like some of the international journals were basically saying that instead of using the dipstick, because it's not actually adding a lot in terms of the culture positive UTIs that they're catching, that HPI could be used.
Yeah, I mean, this is Dr. Glanchard kind of like hinted at the question a little bit, but great presentation, by the way. I just left Lutheran, and if you think of someone has UTI, if you're going to send UA, they send urine culture on everyone. So, but I noticed that at County, we just send UA, is it a positive or negative? And like you said, if they're pregnant, then you do the urine culture. So, and depending on where you are in fast track, if you send culture on anything, they are tending kind of like get mad, oh, why are they sending culture on this stuff? But if you in the main, since you're not going to follow it up, there's somebody in fast track that does the follow up. So, what do you actually think about sending UA and urine culture if you suspect someone has a UTI?
I think I wouldn't send a urine culture on everybody, but people that I'm so worried about that I'm going to definitely treat them. And they're very suspicious. They have pyuria, they have symptoms. And then because of the resistance and also to gather data for the antibiograms now, I do send it. It's not on everyone. If I, questionable mild abdominal pain and, the urine didn't show much and I'm not impressed, no, I don't send it. But if I'm impressed and I'm going to treat them, then I send it because I think I'm seeing so much resistance now. Just one other thing to say. If I get a urine and it has pyuria, right, they have symptoms, and they have either discharge, if they're a woman or a man, they have discharge, and they don't grow anything out in the culture, then also think of the possibility that they may have chlamydia, particularly, or GC, but especially chlamydia. And so pyuria plus dysuria, but negative cultures, think of that possibility. And there's a nice article that says who you should do a pelvic on, or which women should you do a pelvic on that have urinary symptoms. And one of the things for it was if they have vaginal discharge at all, then you should probably do that. And in women, the swab is much more accurate than in men. In men, you can go by the urine. In women, the urine is not sensitive, although it is specific, just kind of like the nitrites are. I think you got to use your clinical judgment who you're going to send culture on and which ones.
We continue talking about when we set up for the next presentation.
That's, I have a question about how much does the UAs cost and how much does the urine culture cost? Because I know there's like a number that our coax costs 600. So how much do those cost? Does anyone know how much? I'm just curious because sometimes we kind of are a little bit flip about what you said. So
The dipstick is often a point of care testing. It's not here, but in a lot of places it's point of care testing. The culture definitely costs a lot more. A lot of the downside of sending cultures on everybody is you have false positives. The downside of sending tests, all tests, right? So you have a false positive for a positive culture, and then you treat that person and you have an adverse reaction. So I think you have to use testing intelligently for adverse very controversial topic.
All right, so I'm going to talk about hyperkalemia. Thank you to Dr. Kendall and Nyla and Miguel, and also for your presentation on presentations.
yeah.
All right, so the case. A 65-year-old female with hypertension, chronic kidney disease, osteoarthritis, brought in by EMS for generalized weakness, becomes pulseless in triage. ALS protocol is initiated and the patient is urgently rushed into CCT. So say it's a morning that there's 2 juniors on board and you're not actually needed for the resuscitation. So you have some time to think about the differential diagnosis. What's going through your mind?
Hyper-K.
What else? There are reversible causes of cardiac arrest, including hyperkalemia. But it's something that I want to start thinking about more often because I guess right now I'm so focused on the airway or whatever it is, getting the IV access, whatever it is that I'm doing. It's nice sometimes when there's a lot of hands on board to take a step back and think about these reversible causes. So I'll be talking about regulation of potassium, clinical features, and then management of severe hyperkalemia. So our potassium in our serum is maintained at 3.5 to 5. We're taking in 50 to 150 milliequivalents a day, and most of that is excreted mainly through the kidneys, but also some through the GI tract and skin. And then there's a lot of internal regulation going on to maintain most of the potassium in our body intracellularly. So if you remember back to medical school, the sodium potassium pumps that are pumping potassium in, and those are upregulated by insulin and beta-2 adrenergic receptors. So there's a lot of things that could go wrong. There can be some excessive intake, but more likely it's decreased excretion from kidney damage or the effect of drugs on the kidney's excretion of potassium, or a combination of both. And then internally, things that cause potassium to shift outside of the cell. So acidosis, as potassium is exchanged for hydrogen ions, insulin deficiency and beta blocker use, because that's decreasing the potassium, the function of the sodium-potassium pumps, and anything that causes cell breakdown, so burns, rhabdo, and tumor lysis. So the clinical features of hyperkalemia are nonspecific, like many things. Somebody can come in with paresthesias, weakness, fatigue, nausea, vomiting, diarrhea. In more severe cases, you may see lethargy, flaccid paralysis, and palpitations. So say that patient that came into triage didn't lose pulses and was triaged to Pod A. So you get to pick up one of your favorite chief complaints. And she's complaining of some tingling on her right arm. She's just feeling weak. You're not really seeing anything on physical exam, but just given her history and her age, you decide to send a full set of labs. So you, as the labs are cooking, you work on your notes, and you see some other patients, and the phone rings. Critical value. So you have a potassium of 7.5. What do you do first? First, you want to think about, is this pseudo-hyperkalemia? I don't know how that didn't get caught beforehand. Is it pseudo-hyperkalemia? That's the most common cause of hyperkalemia that we see in the emergency department. So sometimes we just it's kind of like the boy who cries wolf, just kind of glossed over because we just go straight down to, is this hemolyzed? That's what we're expecting. And if we don't see it, we call the lab right away, make sure. Then, is the patient stable? If it is a true value, just because it's been a while since we checked on the patient, just make sure the patient's stable, is on a monitor, has IV access, and get an EKG, is what we're saying. And repeat labs. So there's a progression of findings on EKGs. First things we look for peak T waves, prolonged PR interval. Then with more severe hyperkalemia, so above 6.5, you can start seeing widened QRS, flattened P waves, ST elevation, topic beats, and then onto sine wave, VFib, heart block, asystole. But the thing is, the EKG findings are not always progressive, and they may not always be present. There was a study done that showed that 30% of patients with severe hyperkalemia don't have EKG changes, and it can also, bounce from peak T waves all the way to VFib. So for a value like 7.5, you want to make sure you treat it, mainly by stabilizing cardiac membrane. So here's one of EKGs, no P waves, the QRS kind of goes into the T wave, and that's your sine wave, which is specific for hyperkalemia. So emergency therapy of hyperkalemia, the first thing we want to make sure we do is stabilize the cardiac membrane. So that's can be done with calcium chloride and calcium gluconate. It's a 1-to-3 ratio between both of them. The downside of calcium chloride is it causes tissue damage. So if it extravasates into the skin, it can cause problems. That's why it's only used with large bore peripheral IVs as well as central lines. They have the same onset and duration of action. So it antagonizes the potassium at the cell membrane, and that's how it stabilizes it. Then we want to think about shifting potassium back into the cell. As I talked about those sodium-potassium pumps, we're going to upregulate those, and that's can be done through albuterol. And these are high dose. This is a high dose albuterol, not the same treatment for asthma. It's 10 to 20 milligrams over 10 minutes. For insulin, it's short-acting insulin, and just to make sure you don't make your patient hypoglycemic, add 1 to 2 m's of D50. And then in acidotic patients, sodium bicarb can be used. And ultimately, if we want to remove any offending agents, whether it's drugs or IV fluids, but if the patient needs to actually be able to excrete that potassium, so furosemide can be used 40/80 IV, and then ultimately hemodialysis hyperkalemia, refractory to medication management is one of the indications for emergent dialysis. So what about K-exalate? So the thing about K-exalate is there's aren't too many studies that show that it works. There were just a couple, and they showed that it worked after hours, which isn't, so it's not really necessary to start in the emergency department. And the risk of K-exalate is colonic necrosis, and it just causes a lot of diarrhea. So this is a very short presentation. My key points are, consider the reversible causes of cardiac arrest. Start thinking about that. I'm sure you guys all already do that. For true critical values, go back, make sure the patient is stable, get IV access, get an EKG. And EKG findings are useful, but you can't rely upon them. And you want to make sure you stabilize the cardiac membrane first, and then shift and remove potassium. Any questions?
So a couple things. One thing that may sometimes help you to decide if that hyperkalemia is real or pseudo-hyperkalemia, besides the lab telling you it's hemolyzed, obviously, but is look at the BUN and creatinine. 99%, I would say, of patients who have true hyperkalemia. There are some exceptions, like people on, who are on ACE inhibitors and people on high-dose aldosterone. But for the most part, there's going to be renal failure. So if you have someone who has hyperkalemia and they have a normal BUN and creatinine, and you've done a stat EKG, and that's normal too, I would definitely repeat it before I start going nuts and treating them. And sometimes the lab doesn't always repeat, so doesn't always tell you it's hemolyzed, although you can call them and check.
And I would say you could add bicarb on that too. The bicarb is normal and the creatinine is normal. You're in pretty good shape.
The other thing is, and I always get beat up on this, my experience is that K-exalate does work. Now it's anecdotal, but it is. Now, it does make you miserable, it makes the patient miserable because it gives them diarrhea. So I would, for me, if I could get them dialyzed, I do all the things that you said, and then get them dialyzed as soon as possible. But if I can't get them dialyzed right away, and that's getting harder here. At Lincoln, it was almost impossible to get them dialyzed till the next day. Then to buy time, as long as they didn't have bad GI symptoms, they weren't having terrible GI pain before I started and stuff, then I would use K-exalate to buy time. So if I got busy, or the shift after me got busy, that when all this potassium shifted back and they couldn't repeat the insulin and they couldn't repeat the calcium, and they couldn't repeat the albuterol, at least it gave us a safety valve. So, and if you tell that to Senator, he'll yell at me, but still, that's what I did. The other thing to know that there are some new binding agents out. There's one approved, and there's another one on their way of being approved. And those probably work a little better than K-exalate and maybe a little safer.
There's a paper that came out, I think 2 years ago or 3 years ago, that said if you have hyperkalemia, even if it's hemolyzed or you're not sure, that if they're bonding creatinine use normally, you don't have to repeat it. They all do not have, they all have fictitious hyperkalemia. So if they're bonding creatinine normal, I don't even repeat it anymore. I get EKG just to make sure, but I don't repeat it anymore.
Guys, how do you order the albuterol if it's not regular nebulizer?
5 minutes a month.
Do you use it at times or?
I just write for 5 minutes and just put it all.
At Johnson, you just write in like 16 milligrams.
Yeah,
Yeah,
maybe
it's not
16
even-
units or
Yeah.
whatever.
And it's like
16
in 4 milliliters.
Remember, it's 10 to 20 milligrams, so it's not necessarily that many ampules.
Yeah.
It's the amount of
Too
milligrams.
much 5 and also
Right.
5 is also 5.
Just be aware of giving insulin to end-stage renal patients. It's secreted renally. I'm sure, looks like I see a lot of nods in there. We've all made that mistake before, so give them probably a half dose of what we usually would give, because it's going to hang around for a while.
So,
I agree with that strongly. I've been burned.
Yeah.
If they're not dying, I give 5 units of IV regular instead of 10, and I give them D50. If they're dying and I want to use 10, then I give them 2 amps of D50, and I get a dextrose stick an hour later.
Yeah, I would just give more sugar and I would repeat the sugar. I wouldn't give less. I want to have that long while.
Yeah, because I've, different attendings have said, oh, give 5 instead of 10, give a D50, and then like others have been like, give 10. And I'm like, okay, so.
You can, you just gotta watch them then.
Yeah,
You gotta repeat the sugar, you gotta maybe give them extra sugar. And I do that with the ones I'm really worried about, I give 10. If I'm not that worried about, then I'll give 5 with 1 D50.
So remember though, when you give insulin, you only get a certain effect out of it. If you give 10 units or a million units, you won't get more effect. It'll just last longer. That's why you just have to keep chasing the sugar. Go check that for your face. But a million units of insulin works the same as 10 or 15. It covers all your receptors in your gut.
Because remember, if insulin is excreted in the urine. So if you give them insulin, it's going to hang around. Even regular insulin IV, which is only supposed to hang around for an hour or 2, hangs around for many hours. So you got to watch them. So I always put them on finger stick for Q1H or Q2H, even though the nurses may yell at me for that. Especially stupid.
And then when you get like a hybrid phase, you just, most individuals have told me like just like the BBG, and it's a BBG that's paid, high pay, they get the repeat BBG as opposed to referring to the top. That makes sense. Like they're the two different.
Lately, the BBGs have been a lot of fake news. I don't know what's been going on, but like the BBGs have been.
You can get pseudo hyperkalemia from a BBG.
Yeah.
They just can't tell you if it's hemolyzed.
You have to look at the serum to see if it's hemolyzed, to see the color.
Sure.
So if you have whole blood that's just dilute,
And also,
coagulated, you can't see it, it's still there.
Right, and the creatinine, the B1 or the creatinine shouldn't be affected by quote unquote being hemolyzed either. So you can still use it, but I wouldn't just go based off BBGs can't be hemolyzed because lately, what we've been doing.
You just can't tell the difference.
Yeah, I guess.
Yeah, you just can't tell if it's not smart down.
And use your clinical judgment. You know, like again, you send both, and one is high and one is normal. But you're looking at this patient, they have a normal, pretty normal B1 and creatinine, and they're not acidotic, you know, and the EKG is totally normal. And one of them is wrong, and I would pick the one wrong that doesn't make sense clinically. So always use your judgment.
Good job.
Great, thank you.
Great. Great lecture. Congrats.
I have a quick question for opinion. Recently, there's like one guy for BBG who is super, super quick, but there's a lot of them who are super fast. Is there anything that we can, super slow that we can tell them that it's actually important to do quickly? The last time I was in CCT and it took half an hour, 45 minutes until they
Carry it down there yourself.
I don't think
every
it's
time.
systemic.
Well, if you worry,
You want it fast?
if you worry,
I'll call them. Sending you an EG quick.
well, usually respond to a call, especially if you have urgency in your voice.
What's the patient that you need to quickly?
I have that.
What kind of patient?
We had someone come in and CCT was critical, so we wanted to see what's going on with them.
I mean, if you can send a sepsis tag, tell them it's a sepsis patient. I mean, critical patient could always be sepsis. So that's something they should respond to. But if there's a problem with the specific text, then you can send an email. One of us, Dr. Smith, or go ahead. But sepsis and stroke tags should get it quick, so those are the type of patients. All right, guys, take 5 minutes. I don't think there is post-over, I think we can go home.